Hi, Miss Thelma. Wow, Tom, yours says Elizabeth Glynn. Look at the name, it says Elizabeth Glynn.
I see that. How did I do that?
I don't know, but if you click on your set here, let me see if I can fix you.
No.
Yeah, well, it's going to take more than me, right?
Yes.
You're a cute Elizabeth Glynn, Tom.
Thanks, Thelma. Aha.
You're welcome, Tom.
Thank you, boss.
Miss Thelma, we still have to have coffee.
Yes. Oh gosh, crazy. I have another COVID case.
Oh no.
You know, people just go crazy, and it's just like, oh, everybody has an attitude, get mad at me like I did it. It's like,
wow.
Really? I mean, I have no control over it.
Of course not. And you know what? Listen, my daughter has gone back to virtual school because she's taking she's at the part where exams are for ACE for the Cambridge program at Martin County High School. And she came home a couple weeks ago and said, Mom, can I go back to virtual? I go, and I'm like, no. That was my first response until she said, Mom, if I miss these exams, they don't retake them again until November. And I won't retain that information because they'll be on to their next, classes that they have to take for Cambridge. And she said, I just don't want to get sick, Mom, and not take them. And so what am I to say to that? So she's home, which makes me sad, but she took her first Cambridge test yesterday. So we'll see how it goes.
Well, and it's amazing the connection and how I have a teacher assistant in this room that has a child in the next room. That child has to quarantine too, and what do I do about that class? And there's no contact. Have your staff say, oh, here we go again, but they be out anywhere and everywhere. You see them on Facebook with no mask on at events. But then when they come here, it's like, oh, I can't believe you let that child in and his nose is running. Well, his nose run all year. I mean, what do you want me to do? They got a doctor's note. I'm just over it.
Yeah, I know. We all are. Honestly, we all are. We're all saying, okay, it's time to be over, but I don't think that's going to happen anytime soon. I'm just saying, because, Martin County, I think we're only at 50% vaccinated, maybe a little higher, but makes me nervous.
Oh, Nancy, your picture is beautiful.
Isn't it stunning?
Yeah.
I'm going to pick on Renee when she gets on. She can tell everybody where we're at.
Hi, Kathy.
Hi, Kathy. I like the haircut. Love it. It's shorter, right? You're on mute. We can't hear you. You're on mute. I mute everybody coming in. That's why.
Okay. I said it's set back to my normal length because I just didn't have any haircuts for a year because I was avoiding the personal contact. And yeah, but thank you. Yeah, I like it shorter too, especially now that it's all gray. How are you, Thelma?
Good.
Yeah.
Yeah.
Come on, tell us. We're living the dream.
What did you say? Your birthday?
No, my grandbaby is 6.
You did. Thank you so much. Yes, I put myself on mute because, with broadband and all that stuff, I get worried that I'll get kicked out. So there you go.
So I'm also going to turn to Caroline, just my Carol here, just to see is there anything you need to add. Oh, okay.
Caroline.
All right.
Okay.
Thanks, everyone. Of course, just give us a ring here if you have some specific questions. We're always available for you. Thanks.
You're welcome. And thank you for all the work you're doing, because I know it's been really hard and exhausting and trying to make sure everything's scheduled. And again, thank you for the shout out, because Kathleen on my team has been doing amazing work. we've had volunteers come out, and it's so important, you know, to volunteer and be a part of it. I've had the opportunity to volunteer at the site, and actually had a lot of fun because we played at American Idol if you got the gold ticket or not to come in through. So, you know, I always make everything fun where I volunteer. So with that, Angela, if you want to introduce all the Angelas on the call with you, that they all want to be you, so that's a good thing. It's all yours for the taking.
Well, thank you, Carol. Good morning, everyone. I see a lot of familiar faces, and we're very proud that Cleveland Clinic Martin Health is able to be the sponsor today. I wanted to bring to you guys a topic that is really important to me, but also as far as public health is very important to us, and wanted to take a look really specific to our area. So today we'll be covering the opioid epidemic. I felt it was important that instead of just a hospital perspective, you got a more comprehensive view. So we actually have a couple different presenters today. Chief Campbell, Dr. Marshall, we have Joanna Green from Health and Human Services, Santana Jeffs from our hospital, and then a peer specialist. So they'll be speaking to you. They'll get to introduce themselves with their appropriate credentials when they present. But then also at the end, I would love if you guys take questions down. You can use the chat if you would like, but the panel will open at the very end so that we can then address any questions that you guys might have. And I know we're on limited time, so I believe Chief Campbell is up first, if you'd like to go ahead and kick us off.
Well, good morning, everybody. How you doing? My name is Chief Campbell, EMS Chief for Martin County Fire Rescue. I'd like to go over some stats and some other things that we've been working on here in Martin County, but I'll start with my first slide. I can't get the slide to come up.
Okay, I'm gonna start sharing screen. I think that one.
Thanks, Nancy.
Okay, is that working? Can everybody see
That's
it?
beautiful.
Okay.
Yes.
Okay, so we'll go to the second slide because we're going to talk about the opioid crisis here in Martin County. Now, the science shows us that this issue has been created by our culture. It started back in the 90s when we began overprescribing powerful opioid pain medications, and it's just blossomed from there. Add into that the cheap international shipping and the ease that it is to actually manufacture fentanyl and byproducts of fentanyl that are manufactured in the woods in sheds and packed and shipped actually legally in many cases here to the US for pennies on the dollar. That has been mixed with multiple opioids, which in 2017 really came to a head when we went from a normal level of opioid overdoses to literally 100-fold more. And since then it's leveled off a little bit, but we've had an epidemic ever since. Combine that with a lack of mental health awareness and proper treatment options, and a cultural view that anybody who's addicted to anything, it is a weakness as opposed to a disorder, and a public health crisis, and the stigmas that affect many of the treatments that are out there, which we'll discuss some of those stigmas later on. It creates an epidemic, and it's precisely what we have right now. So I'm going to go to the next slide. So let's talk about some of Martin County Fire Rescue's numbers. This is through the first of the year until April 15th. We've had a total of 16 ODs from opioids, 1 death that was worked by our crews, and we're unable to identify opioids related to people who we've arrived to find out that they're a DOA, which is dead on arrival. And of the 27, I think it was, that we had for the year, I identified 1 that certainly fit the criteria, but I can't say that's exactly what it was because I wasn't there and the evidence wasn't collected by me. That information will come from Sheriff's Office. Those 16 ODs, they cover the entire aspect of the county. It crosses every socioeconomical line and affects everyone. It's in every neighborhood. Clearly, it's in some neighborhoods more so than others, which I'll show you on the next slide. This is the overall Martin County heat map viewed from countywide. You can see Jensen, Stewart, Hope Sound area, even Indiantown area definitely have some hot spots. But to get a better picture, if you zoom into certain areas, you'll see different areas on the next slide that are a little bit more specific. In Jensen, it's pretty wide, across the board. Every neighborhood in Jensen has had opioid overdoses from our stats. No neighborhood is an exception. Even in Sewell's Point, we have them, even though not a lot shows up in Sewell's Point. The next slide, excuse me, is the South County heat map. And Hope Sound has a pretty strong area right around Bridge Road and US 1. That's a really hard hit neighborhood. The next slide shows the actual city of Stewart, which we can only comment on what we have run within the city of Stewart. And you can see that area near the airport is really, really heavy area. But that's only what our fire rescue units have run in that area. It's not our zone that's covered by the City of Stewart Fire Rescue, but we still end up going into their zone often, and you can see the results of that. Now, when you look at our numbers, they're clear hotspots, like we said, and it does cross every neighborhood, age, gender, and socioeconomical boundaries, and it's clearly a systemic problem. The problem is, how do you create such a large systemic issue? Well, what we've done here in Martin County with the next slide, we started a CORI program. It's the Collaborative Opioid Response Initiative. That was through the OD2A funds that came in about 1.5 years ago. Ms. Michelle Miller contacted me, and we talked out different possibilities of working together on this, and we came up with a collaborative effort in which we share, because the Health and Human Services, where Michelle Miller works, they're part of the BOCC, so I'm able to share information with them patient-wise without violating HIPAA. So I get them contact information for an opioid overdose, in which then they have a medical social worker who specializes in this to contact the person who had the overdose and discuss treatment options and whether or not they need or wish treatment, which obviously if they've overdosed, they probably need treatment. And we've shown a little bit of success with that program. The biggest problem we have is contact information. What we pick up in the field does not always translate to the true phone number. So often these overdoses will be in restaurants, bathrooms, and or what have you in public areas, and somebody else will call in. So unless the patient is, after they're revived, shares the correct contact information, we don't have the correct contact information. So that's only through that are we able to actually make the right contact. So that's been a big hurdle that we're still working on trying to get through. The next one we started was a Leave Behind Narcan program. And the idea behind this is to keep people who do have these issues alive until they decide to finally get some treatment. What we found is that 5, 6, 7, 10 contacts and overdoses, you don't often get them to follow any kind of treatment modalities. So the best thing we can do at that point is leave Narcan with them, educate them on it, and educate their family with it. So if they do find them again, we can get them revived with Narcan as soon as possible, because it's all about, at that point, brain cells. That program was facilitated through our community paramedic program, which we started this August 2020. It was enabled by a grant through the state of Florida through a matching grant. They do 75%, we match 25%. And we're able to put a single fire medic of ours on a 40-hour week. And his sole job is to be a community advocate. And in this case, we feel one of the biggest ways to make an impact is through the opioid crisis, because so many people are affected by this. So he has spent the last 8 months of his life learning how best to help people, not only with opioid, but with fall prevention, et cetera, and educating people on how to get better care despite what they have or don't have. And his job, his name is Rob Shagnon. He's fantastic. He's doing a great job. Definitely the perfect choice for this that position. And he's worked tirelessly. And he was actually able to get us the grants for the Leave Behind Narcan and set everything up with different pharmacies to allow us to supply us with the Narcan kits. And he's the primary contact point for receiving the Leave Behind Narcan through Martin County Fire Rescue. Through these programs, the community paramedic program is continuing to show progress in getting to know who the people who overdose and are transported by Martin County Fire Rescue. He's established pretty good working relationships with many of them. And it's a program that takes time to really show that success. However, the last thing that I didn't show here was is the MAT program that we've been able to work with Cleveland Clinic to get established in Martin South. In my opinion, the way we have that set up, which I'm sure other people on this panel who are directly involved in that are going to talk about in depth, it has been remarkable thus far, and it is definitely working. And I'll leave that for other people to discuss the depth of that program. Outside of that, that's what we do here in Martin County. These are our numbers and that's our stats, and it's clearly a problem, and we're doing our best to address it. I hope I wasn't on mute the whole time. All right, so I'll leave it to the next. Thank you.
Thank you. And you were not on mute. So, because I would have been going, no. So, Angela, if you'd like to introduce your next panelist.
Sure. So our next panelist is Dr. Marshall from Tykes and Teens. I think probably everyone on this call knows her. And she is going to be talking about stigma and rethinking the disease for us. So Nancy, if you want to go ahead and start her slides, that would be great. And Dr. Marshall, I'll turn it over to you.
Thank you so much, Angela. Appreciate it. Nancy, are you able to pull up my slides?
Sorry, I'm having a little bit of technical difficulties. Wait, here I go. All right, you're probably just gonna have to watch me as I fumble around trying to share my screen. And then,
Probably trying to figure out there's a lot of presentations too.
yeah,
So
there's a lot going on. Okay, can you see it now? Is it up?
not yet.
It's not up. Which screen are you seeing?
Just
We
the-
see your face.
Oh. Okay.
So this is when on Zoom you go do 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 do.
Okay, I can't figure out why you're seeing my face. Oh, you're seeing,
You're just seeing your screen picture, Nance. Your beautiful headshot, not the live.
let me, screen one. Okay.
There you
got
go.
it? Okay.
We
Yay.
got it.
That.
Thank you,
Yay!
Nancy. Yay. All right. I'm Dr. Neshka Marshall from Tykes and Teens. I'm a Chief Clinical Officer. I'm going to talk about rethinking addiction today. Do I have power over the slides?
Well,
Oh,
no. There we go.
okay. So the way psychology sees it today, and I'm actually very grateful for how far we have come, we don't actually use, when we're talking about diagnosing, we actually don't use the words addiction, abuse, or dependence like we did before. Reason being is because addiction can be such a complex matter, I want you to consider, for example, if I put a grape on a windowsill, can you pinpoint the moment that grape stops being a grape and starts being a raisin? So addiction can be much like that in that it is more of a process and can be a spectrum. So what we do is really identify a series of problematic symptoms that come with use. And then we classify it as either a mild use disorder, a moderate use disorder, or a severe use disorder. Can I see this next slide? And here are the main 12 symptoms that we are looking for. So again, I believe 3 of these constitute mild.
Okay.
More than that would be, I think about 3 or 4 or 5 would be moderate. And then as the number of symptoms go up, you have the severe. And again, the reason why this is a more effective way of looking at it is because we're not waiting. We're not waiting for it to perhaps get worse. And again, to wait until that grape becomes a raisin. Next slide, please. And so there are some models that describe how the disease process happens. And again, these are, models of the way addiction was looked at previously, and maybe even for some people, the way they see it now. So the disease model, also known as the medical model, really focuses on the brain and the changes of the brain that happen with use, because there's both functional and structural changes that actually do happen. So of course, there is some, meat to this. And really the best mode of treatment, if we're looking at the disease model, is pharmacotherapies or the suitable alternatives, which, we have the medical assisted treatment. Then, of course, unfortunately, we have the moral model, where really drug use means naughtiness or misconduct. Addicts are seen as lacking morals, willpower, and self-discipline. So therefore, treatment has to be more of punishment. And oftentimes in extreme versions, and maybe in the past, individuals might have been incarcerated due to drug and substance use. And then a very popular model, we have the spiritual model, also known as your 12-step programs, which of course work for a lot of individuals out there. So I'm not poo-pooing these. But basically with the spiritual model, we're talking that there's a spiritual deficit and that results in substance use, and we want to, that allows the individual to fulfill an emptiness that is inside. So therefore, the best mode of treatment is a path to a person's spirituality. And recovery means learning the virtues of humility, acceptance, recognizing that one is powerless in order to help themselves, and seek healing or surrendering to a higher power. So we're all kind of, I'm sure, familiar with these. Until finally, which I am very grateful for, once again, if you switch to the next slide, we have come to know in our field the Biocycle social model, which kind of pieces it all together. Because if you saw at the beginning when I shared some of the previous models, is that they all have a theme, and that theme is that the disease is within the individual, and therefore is the individual's problem and opportunity to seek help. Now, of course, we don't want to take that responsibility away for the individual, but as you see, the Biocycle social model opens the door to social factors that are at play as well. And so what do we mean by those social factors? Next slide, please. So let's consider trauma, for example. What we know from the ACEs study, or also known as the adverse childhood experiences, is that 5 or more ACEs allows an individual to become 7 to 10 times more likely to have substance abuse type disorders. 2/3 of IV drug users report abuse and traumatic childhood events. Individuals with 3 or more traumatic childhood experiences have higher rates of alcohol and drug abuse. And I know a lot of times in treatment facilities, you are going to find that the majority of the individuals in treatment do have a trauma background. So there is that social aspect of the experiences that the individual is in or has grown up in. And then also along the lines of the social aspect, next slide, please. What about connections? There is a connections theory that states that how we interplay with others is also a major factor in whether or not an individual develops a substance disorder. As individuals, humans are very social creatures. We actually, in studies where they assimilate the idea of rejection, the same part of the brain lights up as though danger is happening. So the brain does interpret rejection or disconnection from individuals as a danger. And this study kind of shows a little bit deeper look at that. Can we play the video? Hopefully you can hear it. I don't think we can hear it. Nancy? Oh, no.
Yeah, I'm not sure why, but
Are you on?
I've never been able to get sound to go on a Zoom. I don't know what the deal is.
Yeah. See, Angela, this is why I don't embed things.
I know. Nancy, do you want me to email you the link?
I'm wondering, Nancy, could you go to YouTube and find the rat study?
Well, I think I can hear it in my office, but I don't know why it's not going through on Zoom. That's why I took it off mute, to see if maybe that would trigger it.
Okay.
But it doesn't seem to want to work.
Okay, that's okay. Well, I can certainly explain it. So historically speaking, they used to do a lot of research on addiction, in that they put a rat in a cage with water and then the option of a substance. Eventually what that rat does is that it prefers the substance and will use it and continue using it until its inevitable death. And again, that was our view of substances, that our brain wants this substance and we are going to use it uncontrollably until our demise. But then a researcher decided to try something different. So instead of the rat being alone in their cage, they put them in what they deemed as rat park. And I do encourage you to watch this video on YouTube, because it is pretty interesting. And in Rat Park, they put the rat with all their other rat friends, with balls and other things that are stimulating to rats. And they also had water as well as a substance. And what they found, and they called this cage Rat Park, what they found is that very seldom did the rats choose to use the substance. And then they considered, what does this mean? Well, they looked at a Vietnam study where a lot of individuals that were away at war used heroin in order to dull the pain that comes with being at war. And people panicked, believing that, my gosh, we're going to have all these addicts come home. What are we going to do? Well, what happened is when these veterans had left the trauma space of being at war and using that substance to be able to manage having to do that, when they came home to their families, to their loving households, they found that very few of them actually did develop substance issues. So again, the idea being that it's not so much the substance versus the want to connect, and human beings want to connect. We will connect to what is available when we are unable to connect to others. And the implications of this when we talk about the cycle of addiction. Can I have the next slide, please? So if you consider, we have a drug abusing parent who has difficulties, struggles connecting.
Hi, Renee. Oh my God. Watching that person too, because I'm.
Oh,
I'm so good.
Okay, so we have a drug abusing parent, and let's say that they struggle, had connected to drugs because of issues within their own relationships and difficulty connect from, childhood for whatever reasons. And of course, because of their substance use, their behavior may be erratic, unhealthy, and that obviously the child ends up being exposed to. So when the child is exposed to that kind of an environment, the brain connectivity ends up being impaired because that child needs the ability to connect in order to have those brains become nice and healthy. And then of course, through the erratic behavior of the parent, they also are enduring toxic stress. So then that child's brain without intervention ends up being the teen brain. So because of the deficits that have happened with that caregiver not connecting with that child, we might have the teen having that same issues with connecting with their peers. And again, because of poor brain development, they might have academic issues. And then there's the emotional pain and trauma of their experiences, which oftentimes can lead to early onset of drug use. And I can't stress enough of how often I try and promote that individuals that are in diversion programs that are caught early with substances, particularly teenagers, that it's always a great idea to refer them to treatment, because most often than not, the substance is not the primary diagnosis. There's usually an underlying diagnosis. So then what happens when teens grow up to become adults, and then and a likelihood to become adult using drugs. And of course, the cycle continues. So, but with the addition of that psychosocial model and the fact that there are these sociological impacts of an individual and substance use, that means that there is that there's an opportunity here for all of us as a community to stop looking at this as just the problem within that individual. May I have the next slide? So again, I'm inviting individuals to not just focus on the individual recovery, but let us talk about social recovery. What can we all do together as a community to ensure that individuals grow up in a safe, healthy environments. And then of course, instead of isolating and stigmatizing and seeing this as a moral issue, because that only makes things worse, if you consider the connection theory, to really having an opportunity to have relationships with these individuals, make those connections, have unconditional support for those individuals. So really, in a nutshell, what I'm saying, and if I could just get the final slide, is that the bigger picture is that this involves many complicated factors that all interact with each other. It deserves our empathy and our understanding, and we all have stake in the game. And through, I know we do a lot of work with trauma-informed care, that, there is an opportunity here that we can all become sources of healing for individuals that are struggling with substance use. And that is all.
Angela, if you want to introduce your next presenter.
Sure.
And
So
thank
our
you
next,
for this. And just real quickly, thank you for this information, because this is something that we don't want to talk about. Let's be realistic. People don't want to talk about this. They don't want to believe it's happening in their community. And if we all as a community don't come together to address it, it's just going to progressively get worse. So thank you, Angela, for putting this together, and your next presenter.
you are very welcome. Our next presenter, this is going to give you a little bit of a hospital update, is Dr. Santana Jeffs. And she is going to give you an idea of what's going on with our OD statistics from our ED, our MAT and peer program. So Dr. Jeffs, take it away.
We can't hear you, Santana.
Better? Okay.
Yes.
All right. I am the Senior Director of Hospital Operations for Cleveland Clinic Martin North. And about 2 years ago, we can go to the next slide. About 2 years ago or so, I started working with Angela and Lisa from New Horizons on how we could put together a peer program for the hospitals. So we did a lot of investigating to determine what the best method would be in order to make this happen. So in 2019, we were able to start piloting the program at our South ED. That ED is a little bit smaller, so it's easier to monitor, and also they typically have a higher number of patients that were coming through the ED that this program would benefit. So when we looked at a peer, we wanted to identify someone who is in recovery and they've been sober for more than 2 years, and they've passed the level 2 background check. They've gone through training and they're employed by New Horizons, and they were available to listen and share recovery options 24/7. Because one of the things that we really were able to identify was that a patient will connect better with a peer than they will with a employee at a hospital, whether it's a doctor or a nurse or even someone in EMS. With the peer program, they assist with the workload with the caregiver, so we actually ingrain them into the workflow in the ED. So that way there's dedicated roles, and the nursing team and the physician team know how to hand off to a peer. They provide the best options and resources for the patient. They're able to initiate that treatment with the patient if the patient is willing, and it helps so that way they can continue treatment after leaving the emergency room. And since 2019, we've been able to develop where we have the peer program at all of our hospitals currently. Next slide. And then recently, we've been able to partner with Martin County Fire Rescue and Chief Campbell, and we've been able to develop a MAT program, also known as a medically assisted treatment. This is an important layer, and we didn't have this in the beginning, and it's really crucial to make sure that we can help the patients, and as they're leaving the hospital, they get that first initial dose. Right now, what we're offering is Buprenorphine, which is also Subutex. And so our ED medical directors have been on board and have been working very close with Chief Campbell's team and also our peers to make sure that this could happen. Next slide. So the way that the program works is that the peer coordinates supportive care for the patient within the community. Martin County Fire Rescue and Health and Human Services are notified and can provide additional support upon the patient being discharged from the ED. And currently we have this program is only in place. We did our pilot again at South Hospital, and then we will continue to move it through North Hospital and hopefully eventually in St. Lucie County as well. So our overall overdoses in Martin County Emergency Department, a different view a little bit from what Chief Campbell was able to show. In 2019 from North Hospital, we had 129 overdoses, and we had 113 at South Hospital. 2020, we've seen a dramatic decrease in that. We had a steady 78 at each location. And then this year for the first quarter, we had 17 at North Hospital and 29 at South Hospital. So the last thing that I'll leave you with are, in the event of an overdose, things that we should do. You should always call 911, check for responses and breathing, give rescue breaths if not breathing, give Narcan nasal spray, roll the person onto their side, and then seek immediate medical attention. Common things that people tend to do that they shouldn't: we should never leave the person alone, never put the person in the shower, do not give them coffee, do not have them walk around, slapping or hitting the person to wake them up, and try not to inject another substance. So key takeaways: collaboration with other agencies and community partners is vital. This program would not have been able to happen had we not partnered with New Horizons and Martin County Fire Rescue. It truly has been a community effort, and it's been extremely successful. It's something that, you know, Angela, Chief Campbell, myself, and Lisa, we've been very proud of, and we've been working on for many years. This is not a choice, but a public health crisis. Education and communication is key. This is something that we have to continue to talk about and make people aware, because it takes everybody to help this patient demographic. And patient care must come first. Thank you.
Thank you, Santana. So our next speaker is from Health and Human Services here in Martin County. Joanna Green is going to speak a little more about the OD2A grant and program. I know Chief Campbell touched on it earlier, but Joanna, if you'd like to go ahead with your presentation.
Thank you, and thank you guys so much for allowing us to talk about this program. We are so proud of what we're just getting off the ground with here in Martin County. And for those of you who I haven't had the pleasure to meet yet, I'm Joanna Green. I'm the Human Services Supervisor here at Martin County Human Services. I supervise our treatment courts, so our juvenile programs of REACH and delinquency diversion, civil citation, as well as mental health court and drug courts. So you can imagine we see some of the effects of the opioid crisis here in our county and nation. Ultimately, we see it on a face-to-face basis daily. So we definitely have a motivation and a push here in our office to help alleviate some of the suffering that we're seeing as a result of this. And I'm very proud that our agency is helping to partner with Fire Rescue and Cleveland Clinic so that we can get the word out, as well as provide some linkage to services, which is one of the main goals of our grant. So just to give you a little bit of background about what the Overdose to Action grant is, it's a 3-year grant, and overall in the state of Florida, it's going to allocate $6.6 million to selected counties. So it's a long-term process, and we are making some headway very early on. So again, I'm super proud of our community and how we've already banded together and made some really unique successes. There were 14 counties that were selected based on their high rates and their counts of fatal drug overdoses. So we were one of the counties that were selected. This is a grant from the CDC, and it was awarded to the DOH, and we partner here at Martin Human Services. We partner to help implement those 3 major goals. And one of those goals is to increase the timeliness of surveillance data so that we get information more readily and more accurately. We're also partnering to help implement evidence-based research with some of that data that's being collected. And we're also creating new means to help connect consumers with linkages to care. So that's really where we focused most importantly with our end of the situation in Martin County, is we're trying to provide those linkages, and we're trying to implement specific strategies to prevent opioid abuse and death. So we are so happy to work with Martin County Fire Rescue. One of the things that we did early on was hire a bilingual certified behavioral health case manager, and she's worked very closely with Chief Campbell and Rob in helping to not just identify people who've been affected by an overdose or are coming up in some of the ranks as far as the data is coming through the system, but also to help link them to care. So she's been very active in contacting individuals. As Chief Campbell shared, we were able to do all of this within the constraints of HIPAA, which is certainly very important. Another thing that we were able to do very early on was to hire a certified substance abuse peer specialist. And he has extensive experience in running treatment groups, and he's certified as well. So we have two very capable, very qualified, very experienced professionals on our team, and they are ready to roll as far as putting this help in the laps of people in our community who might be struggling in some way. So one of the things that they do primarily is to contact those who we are given the name of who've been experiencing this, and they offer free case management. They offer free support. And we're still in the means of making all of that work together. So next slide, please. Show off some of our things that we're so proud of here. We might be a little obnoxiously proud of what we've been able to do already, because we didn't have a lot of direction as far as we knew that we had the funds and we knew that we had such a dire need, but we wanted to make sure that we were customizing it to what Martin County really needed. So for example, the billboard that you see in your upper right corner, we kind of came up with that on our own, sitting around the table, brainstorming. Of course, we used the CDC's preliminary information to kind of provide a jumping off place, so to speak, but we wanted to keep it really simple, and we wanted to keep it very basic so that people would grab the idea and hopefully make a call if they found need to do so. We also use the radio ads, but I can tell you very strongly how proud I was to be on US 1 in my commute and see our little billboard up there. And it was about a month that it was displayed in several locations. So we felt like we were at least getting the word out in a very traditional way. But our case manager also was canvassing the area and heading directly, like in person, to local businesses and offering to distribute our selection materials. So that was another area where we kind of did everything we could think of, even with the constraints of COVID, to at least let them know that these services are available, and any idea we had, we kind of took it on and ran with it. And another thing that we did very early on was offer this town hall virtual discussion. And we are so grateful to Chief Campbell and to Dr. Marshall for participating in that. So if you could pull up our next slide, we can show off that. And again, it kind of doesn't really do it justice just from looking at the picture here, because we had a virtual conversation going on simultaneously in which people can ask questions, and our expert panel could give their degree of their vantage point and what they've seen and what they believe some of the commonalities are. So we're hoping to hold another one of these very soon in the future so that we can kind of follow up on not just what we've been able to put in place, but maybe there are some aspects of this situation in the county that are changing, and we want to be able to address it in a very real-time way. Next slide, please. Some of the challenges, as you might imagine, I hate to use this refrain, but you know how so many times the conversation starts with blah, 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 and then COVID. And I guess that is kind of a blanket excuse in a way, but it's also a very real thing that we've all experienced. And so we were, guns blazing, ready to go off and take on the world and let this thing just flourish. And we really struggled since there weren't the health fairs that might be taking place, or there weren't the in-person meetings that we would normally be able to take advantage of. So we developed multiple workarounds and scenarios to try and continue to find a way to distribute information in as small of a way as possible. But we did manage to have, as you saw from that previous slide, successes might look small, but each one of those individuals is representing a family and is representing a community. And so I know that, we sometimes in this realm of public service describe, even one individual is worth it all. But we certainly value the impact that that one individual will have in the larger community. Some of the other issues we had as far as getting that information out is that people often will want to share. If you get a phone call from the case manager offering free support or free linkage to services, they're kind of like, who are you? And why are you calling me? And what's going on? And they're naturally, in this age of information, they're a little skeptical. And often when she's describing, this free service, they're kind of like, okay, but what's the catch? It's free, and there's no additional line there. So sometimes the simplicity of the program has been challenging for people to kind of digest that. What do you mean this is just free? And what do you mean this is just because we need it? Yeah, that's exactly it. I'm super proud too of, I just want to brag about our peer specialists. In our office, we're all kind of a little family as far as how much we hear each other working, and you can overhear how kind and compassionate he is, and he connects with people, and he has great experience doing this beyond his certification. So we have very capable professionals that are doing their best to connect with individuals. And one of the first things that our case manager often hears once they maybe give a moment to listen is, okay, well, I don't need help, or, thanks so much, but I'm okay. And, we may know on the other side of things that this is their second overdose, or there was some event in the matter of days that had already occurred with them. So our concern is great that we offer the information. And honestly, sometimes people do call back in a couple of weeks or 3 weeks and say, I wasn't ready to hear what you had to say a few weeks ago, but now I'm curious and explain that whole thing to me again. So just the act of reaching out, you never know, if there's going to be a later follow-up with someone who just is ready at that time. So the information is there. We also have experienced the scenario in which we're working on, how to approach some of these issues that COVID is seemingly becoming less of a concern as far as maybe being in person. So we are actively trying to get on the list of where we might make presentations and let the community know in person. So if you've got some in-person meetings coming up at which we could share this information, we would be thrilled to do so. You can contact me, or in a couple of slides, we have our direct case manager and peer specialist information. Thank you. Somebody's reading my mind about those slide changes. Thanks. Again, so we are working hard to develop leads for outreach events. Now we're seeing some health fairs start to happen. We are also actively reaching out to medical professionals that might have a private practice where we could at least display the information, in people's waiting rooms or such, or even retail space break rooms where people might have to, just take their break and they can take down a number and at least be equipped with the information so that should they need it, God forbid, they've got a quick number to call on for help. And we're also doing our best to identify the places we haven't thought of yet. So if you guys have ideas, we are happy to take them on. We're small but mighty at the moment. We're doing all we can think of, but we know that we're only limited by our own imagination. So if you've got some other ideas for us, we'd be happy to partake in those. So our next slide does give you the contact information for our certified behavioral health case manager. That's what all those letters stand for. She's our program facilitator. Again, she is chomping at the bit to get out there and, feet to the ground as far as getting the word out. So she's happy to get in touch with you if you need her assistance in just distributing information or linking someone to services. That's her entire role. And Bill is our peer support specialist. And again, he's incredibly capable. And if you have someone who fits this description, we're happy to share his services. He's recently, as well as working with fire rescue, we put him in touch with the Sheriff's Office Behavioral Health Unit for some of those people that they come in contact with that might also benefit. So again, I'm so grateful for the chance to brag on our program. And we know that we are just at the beginning of this, and it's through all of your help that we could even make this larger and more impactful. So thank you in advance. And thank you again.
Well, Angela, if you just let me say, if you're viewing the chat, everybody wants information. So watch what you wish for, because I see this group going, please send me, please, and poor Angela. So we'll try to make sure we can communicate that out to everybody, the information requested. And I'm sorry, Angela, go ahead. It's your turn again.
No, that's perfect. I was going to say, it looks like there's a lot of interest, and for many of your organizations, I think probably Joanna and her team, probably having maybe Maria come and drop off resources and share the information with your staff is going to end up being best. So I did put my email in the chat. I can definitely connect you. I think that we're also going to be able to send this out with the contact information directly to Health and Human Services after. So we are happy to do that. And our next presenter, final presenter, I should say, before we open up for the panel, is someone very special. She is our peer specialist. So Lisa, if you would like to take it away, that would be great.
Awesome. Thank you so much. I'm also Angela Alicio today, as many of you are, who can't change their names, but I am Lisa Norman Cervanic. I am the peer specialist, and I've been working on this with many of you for 4 years now. Over 4 years, we've been working on this whole program. So I am thrilled that so much of our effort has all come to pass, and it's going forward and very successful. So thank you, everybody, for all of your support and efforts in this community to help the addicts. I am a recovering addict and alcoholic. Everybody say, hi, Lisa. Hi, Lisa. Okay, now you've all been to your first AA meeting. That's how it works. Even though I couldn't hear you, I could see you. I, this summer, by the grace of God, will celebrate 33 years clean and sober. And it's all— Yay! I am so excited, I can't tell you. So it has been my life goal and mission to help other people achieve the gifts of sobriety that I have been given. And my whole journey started with years of relapsing, progressively getting worse, losing all hope, being chastised by the community and family. And I came from a good home and a good family, okay? Yes, there were dysfunctions and everything, but Lisa was the black sheep of the family, and nobody wanted to talk about what was wrong with her. Although we were a very public family, and my father was a politician where I'm from up north. Lisa was always in trouble. Lisa was always party hardy. And it became to an event where Lisa couldn't just stop partying, and she couldn't stop herself. And then it became the daily reprieve that I needed to use just to get through the day. And I didn't even want to. I would try so hard to not even drink or drug before 10 o'clock in the morning. And by 9 o'clock, I was pacing the floor, looking at the clock, looking to see what my son was doing. And I wouldn't even make it till 10 o'clock. At 9:15, I had to use something. It was absolutely horrible. I didn't even want to use anymore, but I felt like I couldn't live without something. And that's how so many of our friends and family and loved ones feel, especially on the opiates. The high is gone, the excitement is gone, the fun is gone, and it's pure hell that you're living, okay? And I had many suicide attempts, self-destructive behavior, and they were going to take my son away. And on August 23rd, 1988, one of my family members tracked me and found me after a 3-4 day binge on many, many different substances, and dropping my son off places that I couldn't remember where I left him. And they called AA. I was going to jump off the Peace Bridge over Niagara Falls on that morning. And there were many times that I just wanted to die because I felt I couldn't stop. And they called AA, and AA sent a woman to 12-step me, is what they called it. It's really peer recovery work, okay? She came and she talked to me and told me her story, and that she was a recovering addict too. And I couldn't believe it. I'd never seen anybody look so good that partied like me and really had their life together. And she said, I can tell you how to do this. You take my hand and I'll help you through it, and you can get better. And I was told in rehab that you're not a bad person, Lisa. You're not a bad mother. You're sick. You have a disease, and we can help you. And that was the beginning of my journey. to a lifelong victory over victory after victory of raising 2 sons by myself and going to AA meetings and raising my hand and saying, I need help, and then giving it back to others. So I am also a treatment professional. I'm the representative for New Horizons for their peer recovery program in the ERs and also with mobile response. I'm also a marketing director for Pinnacle Wellness Group. We do medication assisted treatment outpatient. I'm a CIT trainer and on the board and an interventionist, and putting all of that together, I'm able to help other people find their journey in recovery. And anybody who's willing, we're willing to talk to. The partnership with Cleveland Clinic, by the grace of God, just changed all of our lives. They are so proactive on wanting to help us and help the addicts right where they need to be. At their worst possible point is when you want to get them after they overdose and they end up in the ER. So people, the ER staff so willingly ask the person if they want to get help, and they're so hurting and so suffering that they a lot of times say they want to get help, and they call mobile crisis at New Horizons, and they call me or one of our peers, and we go to the ER and sit down and talk with them. And it's just an amazing experience of one addict to another. There's a bond there and a freedom and an openness that you won't find anywhere else. That's why it's so successful, and why AA and all the support groups have been so successful for millions of people over all these years. We connect them to whatever is best for them, whether it be a detox or a treatment program, inpatient, depending on their situation, or an outpatient program. But over the years, and we've been doing this for years, one of my biggest difficulties was what happens on those nights that, and this happened a few times, where it was a Friday night at midnight and I can't get a hold of anybody to give me a scholarship for somebody who has no insurance, is not safe to go home, they're high risk and have already overdosed 10 times, okay? What do I do with him until Monday or Tuesday when I can get him into an outpatient program? They're going to go home and use, because the severe precipitated withdrawal after being Narcan and then being in the ER may be stabilized but released. The withdrawal is so bad that the opiates make you want to use again in order to survive. You're so sick. The draw and the withdrawal symptoms are so severe. So we set up this program to work with Cleveland Clinic on at least getting them a dose of the Subutex to help reduce some of those symptoms. And it does make them many times a lot more less agitated while we're trying to talk to them. It's pretty hard to talk to somebody when they're jumping up off the bed, you know, in the ER, and they're so agitated they can't sit still or think or even communicate. So it kind of helps with that process, plus reduces the symptoms. And then if for some reason we can't get them anywhere right away, because scholarship beds a lot of times unfortunately are scarce, or there's no money or a bed available at New Horizons, we've got the outpatient programs, but that's going to take till Monday or Tuesday to get somebody an assessment. So that's where the fire rescue came in. And thank God for Chief Campbell and his crew that now will go and visit the person wherever they're at, underneath a bridge, at their grandma's home, at the corner store every day, and give them medication until we can get them into a professional treatment facility or an outpatient program. And by then we're starting to really get them on their way into a new life, new recovery. This whole process saved my life, you guys, and the lives of my children and my whole family and all our generations to come. I mean, isn't it worth the one person you can save? If you're a family member who has lost someone, don't you wish one more time they'd been Narcan, or one more time somebody would have came and helped them? Our children, our seniors our moms stuck at home, our young people are all affected by this. And now it's all fentanyl on the streets, which is so incredibly deadly. It's in everything. We get the coroner reports. It's in the marijuana. It's in everything out there. And it only takes a small amount to kill somebody. It's worth a try. And if everyone is just willing to help us and support us and keep this going no matter what, we can change so many lives in all the course of their generations, as I've said. So do I have another screen? Yeah, okay, well, we did that. And what we can offer to each patient, but we want to talk about Narcan, okay? Everybody should have a box of Narcan at their house. There's 2 doses in here. It's very easy. It's a nasal spray. After you call 911, because that's what you should do first, and you check to see if the airways are open, and you put the person on their side and they're not responsive still, you give them a shot at, up in their nasal cavity, the Narcan, okay, while you're waiting for EMTs to come. And this is a reversal of the overdose that's happening. And if that first dose doesn't work and doesn't bring them around, then go ahead and use the second dose, but wait, I think 4 to 5 minutes. Somebody correct me if I'm wrong, but you can get Narcan at different locations for free. You can walk in the front door at New Horizons on Midway Road. And most of the time they're going to give you 2 boxes of these to a family member or someone who's actually using. You might have to watch a little video on the uses and benefits of it, but they're free, or you can get a prescription. I think in Martin County now we're giving it out too. Somebody can talk about that quick. And I believe the hospital now has permission to give out Narcan. So it can be very expensive with your insurance, like $100 and some, but this can save your child's life here, guys, right here. It can totally reverse the overdose and death. So worth everything you have to support these efforts and to get behind us and to help and to get the word out there as much as possible, okay? This epidemic is a real health crisis. It's not people who are losers and who aren't worth the effort, because so many of us grow up and grow and learn and live to be very successful people in our communities. And it's a loved one. It's your aunt's son, you know, and we don't want to lose not one person. And unfortunately we do, but we have a serious problem in the Treasure Coast. People don't realize that we're one of the highest overdose statistics in the state. So please, thank you all for having us. Thank you. God bless you. We love you.
So Lisa, thank you. Thank you, because that was amazing. I'm from Western New York. So when you said the Peace Bridge, I went, what? You caught my eye. So you caught my attention.
It's where I'm from.
I came from Niagara County, so I know Peace Bridge. I know Niagara Falls very well. Thank you for sharing your story. I know it can't be easy to do, but you've inspired, you got me really weepy because, you know, to your point, every life is important and you're an example of that. So thank you. Angela, if you want to open it up for questions, the chat box has been going crazy. So go right ahead.
Sure. So I know we have had a lot of people that would like this information, the screen. So I'm going to work with United Way after this to make sure that that information is shared. And I know there are a couple of you that would like people to come out. I think Health and Human Services will be able to give the best information on resources if there's not an active overdose. And Joanna, I'm not sure if you can answer, but Kim from Volunteers in Medicine was wondering, can someone receive services or be referred if they haven't actually had an overdose?
Right. So our case manager is able to provide information about outpatient treatment or detox or whatever the case may be. So it's not just limited to overdose.
Thank you so much. So a lot of the chat was about how great the presentations are, and Lisa, that you are an inspiration. and then about context for future. So I think we've covered that, but I would love to open it up if you guys want to unmute and ask questions for anyone on the panel. So it can be Dr. Marshall, Chief Campbell, Santana, Joanna, or Lisa. If you guys want to go ahead and ask questions, or if you want to continue to use the chat, that's fine as well.
Maria had her hand up, so she gets to go first. I'm just
Oh,
saying.
yes, please. Yes, Carol, you can take over for me.
Oh, thank you so much. I just want to say, well, not to repeat what everyone said in the chat, but again, first of all, that was an amazing presentation. I think that what you guys are doing is great. I personally, before I worked, well, right now, well, first to introduce myself, I work for Epilepsy Florida. My name is Maria Castillo. I'm the community resource specialist. And so what we do is we help anybody who has a seizure disorder or epilepsy, regardless of financial situation. So I was thinking, I don't know, I would love to get more information because I know sometimes we've had people develop seizure disorders after drug issues or any other kinds of issues related to the brain. So, if have anyone to refer to us, I will put my contact information in the chat, as well as just some epilepsy awareness material if anyone's interested in it. Because, I wanted to share that. And also I wanted to share, I worked in an ER before previously. I was a medical scribe, I'm still in school. So, the amount of overdoses is really high. And I worked in the area actually where we had the Flocka epidemic going on. So we saw all sorts of very sad things that are very hard to deal with. And a lot of people do ignore those problems and pretend that it's not an issue or just let people go and they have nowhere to go to get that help. So again, great presentation. I loved hearing about that. And, if you guys have any clients that maybe have experience with seizures or epilepsy, I would love to be able to help them. So just wanted to say that just to everyone in general, but especially,
Thank you, Maria. Patricia, you had a question. I saw your hand raised.
Thank you very much. Patty Roberts with the City of Port St. Lucie Parks and Recreation Department. We do quite a bit of outreach here as far as Healthy You and opioid addiction public forums. But I have two questions, if I may, of the panelists. I think the one would be directed to perhaps Lisa. But if I came across a person and I did not know whether or not that person had ingested opioids and was overdosing, what happens when I give that person Narcan?
It's not going to hurt them, Patty. They're going to be very mad at you, though. So make sure you step away. They're really agitated, to tell you the truth. If it was opiates and they were having a great high, or they thought they were having a great high, you ruined it by giving them that Narcan. But they'll thank you for it later. But it's not going to hurt somebody if it's alcohol or something else. It's not going to hurt them.
That's, I think, important for people to, I get asked that quite often. Is, what if I don't know what's wrong with the person, but I suspect it might be opioids. So I think it's important for people to know it doesn't hurt them.
Right.
The second question I had, thank you. The second question I had is maybe for Chief Campbell, I'm not sure. But I wondered if someone could address how law enforcement has changed when they get to the home of an opioid overdose. I know here in Port St. Lucie anyway, law enforcement has drastically changed their responses. So maybe Chief Campbell, could you provide some information on that?
Absolutely. Once upon a time, they'd search through the house and look for paraphernalia and what have you, and end up creating a legal issue with it. And then for a long time after, probably the last 15 years or so, they changed to not making it a legal issue at all. And in fact, they weren't even allowed to go inside people's homes, even if they were in there trying to help and giving Narcan. They wouldn't look for paraphernalia or anything else or drugs to actually cause this, turning it into a legal issue. They were hoping they would get treated. Well, the issue has been so significant here recently. The sheriff's office has changed their outlook on things, and now they report all the information to the state's attorney's office. They get as much information about the patient as possible, and they start Marshman Act, if they can, immediately on scene, and our sheriff's officer will go to the ER now. This is just in the last couple of months they started this. The idea here being, if any of them do have any kind of past legal problems, then, or open warrants, they can actually get them into the jail. And the jail, surprisingly, has a really, really good setup there. They do a very good job with how they treat people. They allow MAT, they allow a great deal of things. And I disagreed with their choice to do it, but once I found out their motivation was to get them separate from the environment they're in, and into the jail where there's actually the inability to get opioids and a way to treat it with MAT, and then really good follow-up care afterwards through New Horizons and other agencies. I actually agree with their reasoning behind changing it.
Thank you. That, for me, that's an important message on how law enforcement has changed it's certainly in my experience. In my day, when an overdose happened, law enforcement would come and arrests would follow. And
Absolutely.
that is not what happens up here anyway, is all I can say. So I think that's an important message. So thank you all, and thank you all for being receptive to this message. It's a critical one. Thank you.
So I would call on the next person that has their hand up, but I know you're not Dr. Kokomis. So if you
Thanks. Yeah, appreciate it. Thanks for letting me barge in. I'm Jay Kuchera. I'm a physician. I'm boarded in addiction medicine, anesthesiology, and algiatry pain medicine. I'm active on many different levels, federal levels, brought the Opioid Response Network here, had many meetings with Ellie McCants Cats and ASAM and whatnot. You guys are amazing, by the way. Also the State Opioid Response Network. And then also I've been doing the jail treatment ministry, Celebrate Recovery Inside at Martin County Jail, and so on and so forth. I'm friends with NA World Headquarters and all that. I just came from the American Society of Addiction Medicine meeting over the weekend. You guys are rocking it. Chief Campbell is just doing amazing things. You guys are integrating, all the peer supports. You're doing, honestly, I can't think of how you could do any better, from a national perspective. The only thing I want to say to everybody is, through the very robust structure and process that you have in place right now, unfortunately, we have a subpopulation of opioid disorder that is becoming very severely marginalized and set aside. And what that is the prescription opioid disordered individual. So it would be the soccer mom who takes 10 Percocet a day instead of 4 for her post-surgical problems and whatnot. Your system, as beautiful as it is, with the peer supports that I am so much a part of, and with the evidence-based medications for opioid use disorder and the integration with behavioral services and buprenorphine, I'm sure you're doing naltrexone and the whole soup to nuts. Unfortunately, the prescription opioid disordered individual does not identify. They don't even, the terminology is foreign to them, and they don't integrate into your current system. Y'all got your hands full. Non-medical opioid disorder continues to be, a very serious source of mortality and morbidity, and it's still a huge crisis. But we've forgotten, we have lost the ability to reach, to bring the pain patient, the patient living with chronic pain that is opioid disordered, is now set off to the side in the shadows. And we're in a crisis right now. And I know you all don't see it, and you shouldn't, but I'm in a very, very busy pain clinic. And I just wanted to raise the awareness and float it out there. And then at some point, look forward to hearing how y'all might adapt your wonderful services, in the incarcerated populations and everything that you're doing to go back and start bringing this patient population, this subpopulation, you got to optimize certain services for them. And I'm just going to leave it at that. Please don't forget the prescription opioid disordered patient, because there's a very serious crisis, and I ask you to act urgently on this. So I look forward to you guys contacting me and talking with me. You know, Chief Campbell, you're on cruise control. You're like just up in the stratosphere. I'm not concerned at all about what you're doing for the non-medical opioid disorder and for families and for whatnot. But we really need to deal with the prescription opioid disordered patient with pain. Thanks.
If you will put your contact in the chat for me, because I know you're obviously not Anita, but I'd love to connect with you after this call, because we're always open to hearing suggestions, and that would be very helpful.
Thank you.
I have a comment on that, if I'm allowed to.
Of course.
Sure.
I read every single overdose that we get, even the ones that are listed as potential overdose or altered, comes to my desk, and I read every one of the reports. And I have been surprised by how many people, I mean, 60s, 70s, 80s, who, you know, the husband tells the paramedic that this person abuses their meds, and she gets like this every day, or he gets like this every day. And the people abusing pain meds, you know, I'd say the most that I see is between 40s, 50s, 60s, and 70s, and which surprised me. The number of people in their 60s and 70s who abuse pain meds, and when they make contact, we give that information to the CORI program and the OD2A. They make contact, and I don't have a problem. I don't have a problem. I don't have a problem. And it's just remarkable to me how often I do see that. It is recognized, but how to bridge that gap, because like you say, they do not identify with having a problem. And it's pretty clear by how many times we get to their house, and how to bridge that gap and get them to understand has been one of the big challenges I've seen as well. And thus far, we haven't had very much success with that. It's the ones that overdose or unconscious, unresponsive, and you revive, you know, several times, and it's really hard to deny it at that point. But the ones that aren't fully unconscious, that don't go through that much of an event, it's really hard to convince them to get the help. And it is something we're postulating and looking for different avenues to treat. And it's so hard to make that contact and have that contact mean something. And that's been our biggest challenge thus far, I think.
I'd like to add something to that, if I might also. I so appreciate both of you pointing that out. That's been one of our areas of concern, is that often for teens, it's an athletic injury that provokes dependence over time. And so we're investigating, looking at going to the offices of oral surgeons or pediatricians, or even talking with coaches about the nature of, for example, my son, he was 16, had his wisdom teeth out, and he was like, I don't want to take any of those, because I've been so harping on both my kids, like, until your brain is developed, until you're older, I don't want, you know, if at all possible, any exposure to any kind of chemical in that realm, because the teenage brain is so hyper responsive. And that's one of the areas where we've hoped to, and you guys have spoken certainly so well about that demographic that may experience chronic pain. And I think it's important for us as community members and parents and those who work with youth on a regular basis to also be aware that those sports injuries can be another source of the issue.
It's been
I
such
wanted to say
amazing
real quick,
information. Go ahead, Maria.
I'm so sorry. Oh, okay, thank you. I just wanted to say back on what you guys said earlier. Pretty much working in the ER, that was like the demographic that I saw as well for overdosing, or actually not really overdosing, but abusing medication, because so many people do have chronic pain issues, or they got into an accident, they have like some lumbar issue or like some C4 thing, and now they're taking all this medication, or they have cancer and we have them taking all this medication, and they come in to the hospital, to the ER. Because I guess I worked in an area with a lot of overdoses and drug use, and we would have people sometimes pass every day, you know, from different sorts of drugs. But, you know, I want to add that. Also, I'm kind of interested in getting up with you guys because since I did work in the hospital, I want to see, I'm trying to get my personal agency information in that hospital as well, Florida Medical Center. You know, I worked with the medical director, so I'm going to try to be in contact with them for me. But I was also interested if maybe we could see if it's possible to, you know, you guys were saying it's hard to get contact maybe in hospitals. I don't know. So I just wanted to mention that in case you guys don't have any contact in that hospital. Because I really want to say this is a very important cause, you know, it's a huge problem in our community, especially in Florida. Like, well, down here, it's really bad. So I want to say I really appreciate what you're doing. So
there was a question in the chat. The question was, do you work with families in the child welfare system providing peer support? Lisa, yeah, go ahead, Lisa.
Yes, sorry. We do. DCF has a program called a Safe Call. I'm sure there's a longer name to it, but when there is suspected substance use disorder in the home, they call mobile response at New Horizons, and they call me to go as a peer. And so I've been able to sit down with the parents or one of the parents, somebody in the home that's identified as having a substance use problem, and see if we can connect them to services. And because the goal at DCF has been wonderful, really, over the past few years, I've participated in it, trying to keep families together and get them into treatment or get them into outpatient something so they can get their children back or keep their children. So yes, I can be a peer, not to children. We do have other agencies that help children, but my focus is primarily on 18 years old and up. Does that answer the question?
It does. Thank you so much. We are winding down on our time together. This has been so amazing to hear the work that's going on in our community. For those that, you know, I learned a lot today. I knew there was an issue. I knew there was a problem. And I knew that there were members in our community working on it. But I know, you know, with United Way, if there's anything we can do to help, we are going to be a part of the conversation, and we want to keep educating our community on how we all can come together, because to everyone's point, there is a stigma that anyone that has an addiction problem, that they come from wherever, and it's so not true. Have people that I know that have that issue, and they're not under a bridge or whatnot. They're living their life and maybe not as well as they should be. So I want to thank everyone for being a part of today. Thank you, Cleveland Clinic Martin Health, for sponsoring this. I do want to do one last plug. We all know that Rob Lord is retiring soon from Cleveland Clinic Martin Health. United Way actually got him first, hopefully. We are doing a lunch and learn on May 14th. Rob's going to talk to us about leading during a pandemic, just his career in healthcare, what he sees in the future. And if you know Rob at all, he's the most charismatic speaker I've ever seen. So it will not be in person yet. It's coming, but May 14th, there is a Zoom and learn. If you want more information, go to our website or go to our Facebook page and you can register. We do have limited capacity, so I suggest if you're interested in hearing Rob to register now, and look forward to seeing everyone at the end of July. Thank you. It will be in person. Keep up the good work, and if we can help again here at United Way, let us know, and we will get the information, Angela, to all of you. You get it to us and we'll send it to everyone that's on this call. If we have your email address, we will send it to you, whoever registered you. So Angela, you'll get a lot of emails to yourself because it's your name. But thank you, everyone. Thank you. Have a great day, rest of your day. Thanks a lot.
Thank you.
Take
Bye,
care.
everyone.